Thank you. Thank you for the invitation. So we will talk about the mesh, and I had to focus on the problem of mesh in Europe, excluding temporarily UK, and so it's about what is the situation for our countries, Spain, France, and the other part of Europe. This is my disclosure. So the first line of this is the FDA notification on the April 16 this year. The FDA ordered all manufacturers of surgical mesh intended of transvaginal repair for anterior vaginal wall prolapse, so cystocele only in the notification, to stop selling and distributing their product immediately. And we had Boston Scientific had a recall everywhere in Europe and also in the US. And a Coloplast that had not the recall because of the manufacturer of the mesh is in the US, but the company is in Europe. Do not manufacture any mesh, but you can still use the meshes till you have some. That decision was because the FDA thought that there is no enough demonstration of effectiveness and safety, and they specified that women who had received transvaginal mesh before should continue their normal follow-up care. There is no need to additional action of women with no complication and no symptoms, and women should notify to their healthcare provider if there is any complication of symptoms, including bleeding, discharge, pain or dyspareunia. There is no similar notification in in Europe currently. The TVM are always allowed, but we don't know until when, because there is a lot of regulation system that is moving, not only because of mesh, but you will see that everything will move quite quickly in the next few months. The regulatory environment in Europe has changed over the last 20 years, so it's not just after the FDA notification. The idea is to move away towards a better harmonization, and also because there is a continued lack of trust and increased scrutiny. It's complex, Europe, because of the complex political structure for everything, not only medicine. And it's complex because countries retaining their own identities inside of the European Union. The new regulation, which has been accepted by all European countries, is named Medical Device Regulation, MDR. And that MDR, that I will just detail in a minute, is the new way for any medical device to come inside the European market. All the European countries are involved in this MDR modification, including Norway, which is outside of Europe, but which has some economical relationship with the European Union, and also Switzerland, which is outside of Europe, but there is some European free trade agreement with other European Union. Even Turkey is included in this MDR regulation because of the fact that Turkey has asked to the Europe to be included in the European Union in the future. We keep the same system of notified bodies that are independent from industries, independent for the government, and that have to look at any new medical device to enter in the European market. The CE marking system will also stay. But in fact, all the process that normally go to notified bodies to have the CE marking before to be in the market will be reinforced dramatically. This is a long history, and it has not been started at the time of the FDA notification for transvaginal mesh. It starts for about 10 years ago with two problems with medical device: the PIP mesh implants for breast implants in France in 2010, and also some scandal with in orthopedic hips devices. Then the notified body has been asked to have a new regulation system in 2012, and it was published in May 2017. This we are on the left part of the slide, and the new system which have to be applied in every European countries in May 2020, so in about 6 months. This is the date of application for all new devices, and also for the devices that have to renew their authorization to be marketing. And before May 2024, every devices that we will use for stress urinary incontinence surgery, but also for prolapse surgery, have to be with this new MDR regulation. The previous regulation was the MDD, the Medical Device Directive, which was much more much less with parameters that the new one. So in summary, with this new MDR regulation, all the implanted tapes and mesh for prolapse and for urinary incontinence will be reclassified at class 3, which is already the case in the US, but not already the case in Europe, which means that any of the tapes and the mesh that are currently on the market and that have no to be renewed this year could be at class 2 up to 2024, and all the new devices that have to be developed, and I think we have some presentation this afternoon about new material from the Netherlands. All these new materials that have to be on the market will be directly on class 3, like in the US. So all of this is summary here. For the industry, that new system improved the governance of all these parameters. There is a notified body reinforcements, which means that we have in different European countries many notified bodies currently, and they will decrease dramatically for only few notified bodies, which will probably have lots of work with increased time to answer for any new device regulation, and for the industry, but also for us and for our patients, it will increase traceability of all devices, transparency as well. If there is any post-market problem with any device, it will be easier to access of this, and an increased clinical evidence before, and also if any devices will be want to be renewed in our field. There is some challenges because obviously it will ask an overcost for companies. There is only 2 notified bodies that have been selected currently for this new regulation system, which means that if you has a physician or has an industry, if you want to come on the market with a new device, you will have a long time waiting for to have a notified bodies in this new regulation system. We don't really know currently the capacity of these notified bodies to manage this new regulation system, and it could be also it could increase the time for that, and there is a greater scrutiny around clinical data, which means that probably all of the devices we currently used for sacrocolpopexies, for slings, will have to give clinical evidence, which is not always. You have a text, Johan? I don't know if it's important. No. Okay, so is it the administrative part of this talk, and it's of importance because we don't have we still have in Europe a few meshes that are allowed to use, but all of these companies will have to follow this new regulation system in the next few months probably. It will depend on different countries, but more or less it's the same for all the European countries. For the mediuretral sling, it will be the same probably after the problem of transvaginal meshes, and also for meshes used by laparoscopy for sacrocolpopexies or sacrohysteropexies, it will be the same in the next few years. So we absolutely need, as a physician, to know this problem and to be involved, if possible, in the different clinical studies to validate or not the different medical device we will use for our patients. For the clinician point of view, this is a difficult period for many things, and I'm glad that Anna Rosa Milia will tell you what was the next step in Australia that because they had this problem before us. The fact is we currently have still a poor native tissue repair in the different RCTs, even if there is many techniques of native tissue repair, and there is some publication that started to be published with not so bad results with native tissue repair, and we will discuss that more. But at that time, and all the studies that have compared the transvaginal meshes and the native tissue repair surgery have shown that the mesh had at least a better anatomical outcome. There is still meshes that are there is still some countries in Europe using a lot of mesh, particularly in France and Germany, even if it has already decreased probably, but we don't have the numbers to show you, and even if the new MDR will probably change that fact. There is currently a quite nice level of evidence of mesh, but the problem is the level of evidence for meshes we had used by the past has been withdrawn. So the evidence and the mesh we could use currently for our patients have no evidence, or no evidence, or almost no evidence for most of these meshes. There is at least 4 companies that still sell meshes in France currently. We can have discussion, but no one had a good level of evidence in the literature. This is some papers that have been published previously on the evidence for transvaginal mesh surgery in comparison to native tissue repair, showing a better anatomical outcome. We know that with a longer-term study that even if there is a better anatomical outcome, the functional outcome is more or less the same. But the fact is that with the last meshes we used, the complications such as dyspareunia were more or less the same between mesh surgery and non-mesh surgery. In the last consensus of the ICI, the next one is next year, but in the last one, the mesh repair was still one of the options in the pathway of surgical prolapse, with that specific mention that mesh could be used for anterior repair, mostly, not for posterior repair, and only if the patient fully understands the risk-benefit profile and the fact that we have a lack of data and long-term data is looking for these products. We still have the European guidelines, which is there is no modification of this guideline, even if this guideline is now 4 years ago, and it will probably change with the FDA problem. But we still have these guidelines in Europe saying that there is convincing evidence that the use of mesh is subjectively and objectively superior to native tissue repair, that there is no difference in the need of subsequent operation, which is a bit disappointing because anatomical results is quite good, but patients are do not require lots of surgery, even if they have been operated with native tissue at the beginning. And the fact which is more reassuring is there is no difference in the occurrence of de novo dyspareunia. It is not the same, the same case for the posterior compartment, because still a few years now, and the posterior compartment was not a good option for mesh surgery. But it is interesting to say that in the FDA notification there is no mention on the posterior compartment. The fact is that also in the European guidelines, there is some complication that are attributed to mesh surgery, but we also can see obviously complication after native tissue repair. Pain is a complication that could be observed whatever the kind of surgery, and some complication intraoperatively like hemorrhage or bowel or rectal injury could obviously also occur with non-mesh repair. There is a very recent statement of the Italian group of Urogynaecology that conclude that there is we do not have to close the doors to mesh surgery, but Italian colleagues suggest that the correct use of the mesh currently is within control clinical trials, obviously validated by an ethical committee. About complication between mesh surgery and non-mesh surgery, we recently have published a French database about complication. It's a database which was recorded between 2012 and 2013, more than 4,000 procedures, more than 280 surgeons, gynecological surgeons only. And you see that in France, at least 6 years ago, 75% of our procedures were done vaginally. In that series, just for you to know the context, there is the synthetic mesh, the mesh were used at that period in almost half of our patients, with transobturator technique for the anterior compartment in 60% of the old mesh surgeries. We normally practice apical suspension during surgeries in France vaginally in about 70% of the cases. Half of the case it was the normal sacrospinous suspension with a non-absorbable suture. In 16% of the cases, the sacrospinous suspension was done during the mesh surgery with the mesh itself, and in about 12% with uterosacral suspension, like the McCall procedure or the high uterosacral suspension. In that database, and it's the reason why I present you these tables, we have seen, comparing the mesh surgery and non-mesh surgery for the anterior compartment with more than 1,300 patients in each group, that the rate of complication is higher with mesh. It was the severe complication in the early postoperative course is 3.9% with the mesh group, but it's only 3.9% with mesh surgery, which means that more than 96% of the patient has no complication. And in native tissue repair, even if the rate of complication was significantly lower, it's 2.3%, which is not 0%, and we have some severe complication even with native tissue repair surgery. So that is a very important point to inform our patients. And in longer term follow-up up to 1 year in the same population, we have a rate of severe complication in the mesh group which is up to 8.5%, mainly due to exposure of the mesh. But you see the vaginal mesh exposure rate is 3%, so not very high, but it's obviously increased quite significantly the rate of complication at 1 year, and the rate of 1 year complication in the native tissue repair group is about 4%, which is once again not so low. There is also in the discussion on the surgical routes, it doesn't work anymore. There is also some recent data about. Yeah, it works. There is also some recent data about the comparison of the vaginal surgery and the laparoscopy. It is a French group, a publication which has been done in the European Urology last year, and the objective was to compare the vaginal mesh surgery in comparison to the sorry, I have some slides here. This is the PROSPER trial, if I can show you something. About 260 patients have been randomized between sacrocolpopexy by laparoscopy and I have to wait a bit more. Sorry for that. The main endpoint of that study was the morbidity at 1 year, and the study is still ongoing to have the 4-year anatomical and functional results. And I will show you that in a minute. But in summary, the rate of complication were significantly higher in the vaginal mesh group in comparison to sacrocolpopexy. But I will show you if I can. This is the flow chart, a bit quick. So 130 patients follow-up in each group. And this is, if you can see the other one, yes. This is the main endpoint. The rate of complication was significantly higher in the vaginal mesh group. You see that the grade 2 Clavien-Dindo classification was about similar. The grade 4, the most important complication, was about similar, but the difference were about the grade 3 complication, which was 9% in the vaginal mesh group in comparison to 1% in the laparoscopy group, and mainly it was for reoperation under general anesthesia for some adhesions inside the vagina for vaginal mesh exposure. In that study, about anatomical results on 1 year, we did not observe a significant difference in all the compartments. The only compartment which was a bit different was the apical suspension, which reinforced the idea that even in the vaginal surgery group, the apical suspension is probably one of the most important things. And apical suspension is something which could be obviously done without mesh supports. The conclusion of that paper is that probably in most of the cases, sacrocolpopexy should be the first line of treatment for pelvic organ prolapse, but we know that that procedure is not the best way to treat some prolapse. If we have an isolated cystocele or rectocele, sacrocolpopexy is not the best operation. And even if there is an apical prolapse, that study did not ban the the transvaginal mesh surgery, and one of the reasons is because in that study 6% of the patients which were scheduled for laparoscopy were not operated by laparoscopy because of some technical difficulties. So we need, in regards of the results of that paper, we need to have some transvaginal mesh procedure available for in some specific cases. About mesh surgery, one of the problems also is the difference between the evidence which is available and the evidence that was used by the FDA to ban the mesh in the US and the current practice. For many years we had made some innovation about the surgical technique, avoiding the transobturator approach, but also about the size of the mesh, the technical implementation of the mesh systematically attached to the sacrospinous ligament, but also the mesh itself, which lower and lower material. And the problem, if there is a gap between the time where evidence is published and the FDA notification and the mesh we had used in the past years. Mesh vaginally have also give us one very good information about surgery, and the fact that mesh surgery has been developed towards systematic suspension to the sacrospinous ligament has also give us a new thinking about the need for that sacrospinous suspension, and not only as it was described at the beginning by the posterior compartment, but also by the anterior paravesical space. And currently in practice in France, because of we do not have the mesh we used before, and because there is a few evidence on the mesh that still are available on the market, we use currently more and more techniques, autologous techniques with the anterior approach for the sacrospinous suspension. There is, as you know, specific devices that could be used for the anterior approach of the sacrospinous ligament, the same which had been used with meshes, and it will be really interesting to have more data on this, and precisely about the fact that when we do an anterior approach with a sacrospinous suspension plus a mesh to reinforce the anterior fascia, we really don't know yet what is the part of the success between the anterior approach to the sacrospinous ligament itself or the reinforcement of the anterior fascia. Probably both techniques are necessary for our patients, but even if we do not have mesh or we don't want to use mesh like by the past, the anterior approach to the sacrospinous suspension is probably a good evolution for the autologous techniques. I go fast with this. We also had some long-term results with anterior sacrospinous suspension technique. This was with the Boston Scientific mesh. That mesh is no longer available on the market worldwide, but we had some data of this approach with specific devices to reach the sacrospinous ligament by the paravesical space on both sides, and there is some interesting data at 5 years showing nice maintenance of the anatomical results. So to conclude, our practice currently in France after this FDA notification is we do not have, we officially did not change our practice in terms of mesh indication and contraindication. In practice, we use less mesh, obviously, because we strictly respect these tables, but we still use some meshes for primary high-stage pelvic organ prolapse or recurrent recurrences, and recurrences is even the most part of our indication. Almost recurrences after sacrocolpopexy, which is a procedure which is done extensively in France. We have always respect contraindication, and it's even more important now to respect this contraindication because of the new regulation process that will come up in Europe. We never or almost never use a mesh in a young patient, less than 50. We normally don't use mesh over 80 years old because we have several alternatives, and native tissue is even efficient in this population. We don't use mesh in patients with mesh-related complication, higher risk, or chronic pelvic pain, and we don't use mesh if there is any problem during the procedure, an important bleeding, a bladder injury, or rectal injury. Then even if the mesh is in place, we remove the mesh before the end of the procedure, and we do native tissue repair. Obviously, all our patients have been advised before the procedure, and if they refuse to have a mesh in the context that we know, we don't put them the mesh, of course. And we still think that it's really important to have enough training in vaginal surgery, but also enough training with a specific mesh, which make some problems currently, because we had quite a nice training with the meshes we had used for about 10 years now, and now we have to be retrained with other mesh in specific cases, which is probably a problem for a higher risk of complication in the next few months. So this ban of vaginal mesh in the US represents a major break on the development of new techniques in Europe, and also the new rules of the medical device regulation in Europe, which is not correlated to the FDA, will also help slow down innovations, unfortunately. In France, particularly the laparoscopy approach is one of the approach which is discussed as the first line, but obviously it's not a solution for all of our patients, and it could also be affected by the new regulation system because of the use of mesh and because of the fact that by laparoscopy there is no techniques that have been described with no mesh. I think we must continue to improve autologous vaginal surgical techniques, and even if we have to ban all meshes transvaginally, I think the experience we had with transvaginal meshes has given us a new thinking about native tissue repair, and almost by the fact that the anterior sacrospinal suspension with suture and with no mesh is probably one of the future technique for native tissue repair. Thank you.